All right, Jack. Trauma assessment. You have 10 minutes to complete. You're dispatched to a bar fight. PD's on scene. Gentleman was battered.
Okay. BSI is my scene safe.
Yes.
Is this my only patient?
Yes.
Okay. Mechanism of injury. Sounds like potentially multiple strikes to and around the body here. So some blunt force trauma potentially. I am going to consider additional resources. We'll see after we evaluate the patient. We can always call him. And I'll consider C-spine precautions.
Okay.
So I walk up.
Yeah, you walk up to the patient. He's laying supine, kind of groaning in pain.
Okay.
You notice that his shirt's been ripped. It looks like he's been in a fight. He looks a little beat up.
Okay. So my general impression of the patient is that he's in rough shape. Starts pushing him towards the priority transport and getting him towards definitive care. I'm going to assess his level of responsiveness in chief complaint.
He's responsive to pain.
Okay. Responsive to pain there. Chief complaint. So then I'm going to move into my airway. I'm going to just inspect. Is he protecting his airway?
You notice a little bit of blood in his mouth.
A little bit of blood in his mouth. Is it copious amounts? Okay, we'll have a partner here get some suction going.
Cleared with suction.
Pulled out. Okay. Is he able to maintain his airway at this time?
No, he has snoring respirations.
Okay, we're going to place an OPA. Does he accept it?
Yes.
Okay, I'm going to have my partner hooked up to oxygen, 15 liters per minute, provide artificial ventilations to this patient here.
Okay.
Assist with him. I'll move down to his chest. I'm looking here. Is it moving equally, bilaterally?
It is.
Okay. What was his respirations prior to us bagging?
8.
8. So they're going to work together. My partner's skilled. They're going to make sure we don't work against the patient, get him breathing at a rate closer to 10 to 12 a minute there. So breathing, everything's looking okay there. I auscultate and feel. Do I find any flail segments or anything like that?
No, but you feel crepitus on his chest when you palpate
Okay.
on the left side.
Left side.
And he was breathing also shallow.
Okay.
Before you started bagging him.
All right. So he's getting ventilated now at this point. Artificially, everything's working. Do I see any bleeding? Any large amounts of blood around the person moving in my circulation?
Nope.
No major bleeds. Skin.
Pale, cool, diaphoretic.
Okay, and his pulses.
Tacky, regular.
Perfect. So from there, I'm going to move into, this is a priority transport. We want to get him moving. I'll have my partner try to do a quick history taking, if possible, from PD or anybody that was around. And then we're going to get a full set of vitals on him, blood pressure, pulse, pulse oxidation, pulse ox saturation. And then from there, once I have those, I'm going to move into my secondary assessment.
Okay.
I have a good trauma assessment here. So starting at the head, I'm going to go through checking all around the skull and then checking all the major facial structures on the face. Do I find anything?
He has a large hematoma on the right side of his head.
Okay.
You notice a black eye.
Okay.
Unequal pupils.
Unequal pupils. Nothing in the ears?
A little bit of blood draining from the right ear.
Okay. Those things are noted at this time. I'm going to move down to his neck. I have my partner holding inline stabilization at this point. As I'm checking here, do I find anything or feel anything?
No. You do notice tracheal deviation and JVD.
Okay, tracheal deviation and JVD. So moving down, I'm going to push in on the chest. I lightly palpated earlier, moving through my breathing there, but I'm being a little bit more thorough here. We know it's on the right side, left side, you said, that there's some crepitus?
Yes.
Okay. Real quick, as I auscultate, what do I hear?
Diminished and absent.
Diminished and absent. Absent on that left
Crap on
side.
this side, yep.
Okay. So at this point, I'm going to have a dart. I'm going to needle decompress on this left-hand side here, going second intercostal, mid-clavicular, going through the whole thing, ASAP technique. I place it.
You hear a rush of air, and then now you hear diminished and present. Diminished
and present. Does the breathing change or affect it?
Yeah, he starts breathing on his own again at 12 a minute.
Okay. So moving down, after going through the chest there, I'm moving to the abdomen. I want to visualize. Do I see any large bruising?
You notice a large bruising on the left lower quadrant.
Left lower quadrant? Okay. As I palpate, do I feel anything, guarding, rigidness, anything like that?
No.
Okay, moving the pelvis. I'm going to palpate in and down.
Stable.
Stable. Okay. Left leg moving down. Some torsion on it, making sure I can inflict pain if needed to find it. It's
You're clear.
Okay. CMS intact?
Yes.
Okay. Right leg.
Clear as
going
well.
Down. Perfect. Right arm.
Clear.
Left arm.
Clear.
Perfect. At this point, still maintaining inline stabilization. And because he's not responsive, at this point, I probably would have put a C-collar on him.
Okay. C-collar supply.
Just because it's hard to judge and mechanism of injury. We're going to roll him off of that side with the dart. We don't want to complicate that at all. I check his spine. Do I find any bleeding?
Nope, he's clear.
Deformities? Perfect. So laying back down, I'm going to put him on a board just to assist with transferring him to the ambulance and getting him on a gurney. He's continuing to be ventilated. As far as treatment for this goes, I have a dart. I'm going to want to get IV access. What was his blood pressure?
100 over 60.
I'll probably do a fluid challenge just to check it here. So probably stick with that 20 mil per kilogram of LR.
Okay.
Just see where it's at. And then as we're rapidly transporting, I'm just going to continue reassessing vital signs and making sure to monitor any of my interventions, especially after movement. And that's my treatment plan.
Cool. Good job.
Sweet.